My name is Vincent Rajkumar. I'm at the Myeloma Workshop in Paris, and we had a session this morning on the treatment of transplant-ineligible patients with multiple myeloma. I spoke at the session and gave my approach to the treatment of patients who are transplant-ineligible. The main goal of treatment of patients with, who are transplant-ineligible is to not only accomplish good responses and long duration of responses, but also do so with the best quality of life possible and with the lowest toxicity. I advocate a risk-adapted therapy or a risk-adapted strategy for patients where patients with hyperdiploidy 614 and 1114 are considered as having standard risk disease, whereas patients with the 414 translocation are considered as having intermediate risk disease, while patients with 17p deletion, 1416 or 1420 translocation are defined as having high risk disease. For patients who are standard risk disease, lenalidomide and low-dose dexamethasone gives extremely good 3-year survival of about 75% in patients who are 65 and older, 70% in patients who are 70 and older, and it's well tolerated with very low risk of toxicity, including low risk of neurotoxicity. For patients who have intermediate risk disease, on the other hand, these are patients with a 414 translocation. There's data that bortezomib may overcome the poor prognostic effects of 414, and for those patients I typically use a bortezomib cyclophosphamide dexamethasone regimen and give that kind of regimen for about 2 to 3 years. Finally, for patients with high-risk disease, these patients typically have not done well with traditional approaches, including transplantation for the transplant-eligible patients. Here, I think a novel regimen such as bortezomib, lenalidomide, dexamethasone may offer hope, and this is a regimen that is associated with high complete response rates. In the high-risk patients, unlike the standard risk or intermediate risk patients, I truly believe that achieving CR is very important, and if VRD is unable to achieve that CR endpoint, we may have to change therapy to an alternative regimen to achieve a complete response. Now, the fundamental philosophical differences or controversies in this area of treating patients who are transplant-ineligible revolve around whether all patients need to be treated with the goal of getting a complete response early in the course of disease or not. I'm in the group that feels that for standard risk patients, one does not need a CR. A CR is good, but it's not necessary for long-term outcome, whereas in the high-risk patients, that's a requisite for long-term survival. We also shouldn't forget supportive care issues, and I pointed out that certain patients may present with renal failure and may require plasma exchange. I pointed out that patients should receive prophylaxis for bone disease with bisphosphonates, supportive care with antibiotics, antivirals may be necessary, and these are all part of the package that will provide the longest quality life, the best quality of life, and the longest possible survival for patients who are elderly and ineligible for transplantation. In this population, some of the eagerly anticipated trials are the first trial, which is randomizing patients to lenalidomide dex for 18 months versus lenalidomide dexamethasone indefinitely versus the control arm, which is MPT, melphalan-prednisone thalidomide. This trial will answer 2 questions. Number 1, can we get away from alkylators and use a lenalidomide low-dose dexamethasone backbone? And secondly, it will also give us information on how long should patients get therapy. Is a fixed 18 months adequate, or would patients derive more benefit by taking it for a longer period of time? Similarly, we have to start incorporating other new agents. Carfilzomib has shown activity, and we heard about clinical trials planned by the IFM using carfilzomib twice weekly with melphalan-prednisone, as well as carfilzomib weekly with melphalan-prednisone, and perhaps later on studies with carfilzomib and lenalidomide low-dose dexamethasone. Elotuzumab is active in combination with lenalidomide low-dose dexamethasone and is also being studied or planned to be studied in this elderly patient population. We still need to, as in young patients, we still need to find other new active classes of drugs, and this is something that's going to be a continuous process and where we should be putting our efforts into.